Hello, my name's Steve McClave. I'm going to be the moderator of this symposium, and it's entitled Nutritional Experience in the ICU and Post-Discharge, Impact on Patient Care. The objectives for this symposium, we're going to look at the impact of volume-based feeding on a busy trauma ICU setting at a level 1 trauma center. We're going to look at protein recommendations across the continuum from ICU to rehabilitation, and we're going to look at tube feeding intolerance and the use of small peptide MCT formulas in a group of patients on home enteral nutrition in Rochester, Minnesota. I'm your moderator, Steve McClave. I'm a gastroenterologist in Louisville, Kentucky. I want to introduce my other three speakers who I'm very excited about. A new up-and-comer that we're very excited about is Philip Prest. He's an associate professor of clinical surgery and a trauma doc at the University of South Carolina in Columbia. And he's going to talk to us about the experience they had in volume-based feeding and improving feeding in their level 1 trauma center. Zudin Puchacheri is one of my favorite speakers. He's an intensivist pulmonary critical care doc from London. He's at the Queen Mary University in London. And then finally, again, one of my favorite speakers, Manpreet Mundi, a rising star with Aspen, an endocrinologist and former Nestle Fellow at Mayo Clinic in Rochester. He's the director of the Home Enteral Nutrition program, and he's the one that will talk about use of small peptide MCT formulas for home patients with feeding intolerance. I'm going to start with some comments on big data and just kind of describe to you the level of evidence, these different types of studies, their positive points and their negative points. We currently live in a political, social, scientific environment in which we worry about fake news. We're constantly worried whether the information that's coming to us is accurate. And in a sense, as healthcare professionals, as scientists, we are seeking the truth. And what the heck does truth mean when we're talking about patient care? Well, John Ioannidis is an epidemiologist, and he says the truth of a research finding relates to its reproducibility by subsequent research trials. In other words, its positive predictive value. And probably the most important slide in the few comments that I'm going to make is shown here. And that is the range of positive predictive value for these different types of studies. At the very top are those large, huge randomized controlled trials. But the positive predictive value is not 100%. It's 0.85. That means 85% of the time, if we repeat this study, we would get the same results, or it would be supported by subsequent trials. It turns out a very well done meta-analysis of studies that have low bias and are good quality can approach that same positive predictive value of 0.85. But if it's a well done meta-analysis, but the studies are not good quality, then the positive predictive value drops by half to 0.41. From there, when you go to the individual RCTs themselves, the smaller ones, epidemiologic, observational trials, expert opinion, the wheels fall off the bus. And now the positive predictive value is below 20%. Let's look at each one of these types and look at their positives and negatives. The value of observational trials is it lets us look at large databases or population epidemiologic studies. The problem is the majority, 5 out of 6, are going to be refuted within 10 years, according to this Ioannidis. And the problem is they suffer for the potential for confounding factors. And on this slide is shown what I consider to be a fatal confounding factor. This is a study from Yassine Arabi, does great work. But in this study, he compared patients in the lowest tertile getting the least amount of feeding up to the highest quartile getting the most feeding. And as you can see, the more feeding they get, the worse the outcome. At the bottom is the readout for mortality, and it shows that the highest tertile getting the most feeding had twice the mortality as the lowest. Darren Hyland came back a year later, used the same methodology, and showed the same effect. The more feeding, the higher the mortality. And then he corrected for a single confounding factor, all oral days. When a patient on tube feeding advances to a tray and a diet, he's counted as having 0 enteral tube feeding calories. That means all the patients that are doing well move to the left of this diagram. If Darren adjusted for that confounding factor, look at the numbers. They reversed. And now the more feeding you get, the lower the mortality, not the higher mortality. This is a fatal confounding factor. Epidemiologic studies are also observational trials. And here you have to worry about true factors versus factors that have no relationship to what you're looking at. Look at the two pictures here at the top. On the left, if we had a large population of women like this that are outdoors exercising in the sun, and then on the right, we had a control group that was in nursing home, elderly, not getting outside, I would show you that vitamin D levels were lower in the population on the right. Well, a true factor would be exposure to sunlight. But say my own personal biases, I said, I think it's related to eating cold mashed potatoes. And I would show you that the group on the right, higher content intake of cold mashed potatoes, lower vitamin D levels. That's an example of a null field. I'm focused on mashed potatoes, but there's no relationship between that factor and vitamin D levels. And so the truth of an epidemiologic study is the ratio of true factors like exposure to sunlight or no relationship factors like cold mashed potatoes. Propensity scoring tends to improve on that. It would analyze and stratifying these covariants. It'd give a high score to the sunlight, a 0 or no score to the mashed potatoes. We have a time-honored practice of worshiping large randomized controlled trials, and there's a reason for that. It has the highest positive predictive value, which means that those findings should be the closest to the truth. And they do power analysis, so they are powered to show that effect. And they control covariance, confounding factors, co-interventions, and then we believe they have the lowest risk for bias. But that doesn't mean they're infallible. And here are several weaknesses that we'll show you. One is generalizability. Take the APANIC trial of supplemental PN from Europe. It had great methodologic design, so its internal validity was great. But at the end of the trial, when we went to generalize the results, the external validity, it was poor because they gave this big slug of glucose, and they had tight glucose control that nobody else does. Assessment of harms is the fact that these randomized controlled trials are short in duration. Take Todd Rice's trophic versus full feedings. Those only lasted for 6 days. As a result, they could possibly miss a harm down the road, maybe a year later. And sure enough, in the single center trial he did first, the patients that got trophic feeding were more likely to go to a nursing home than their own home. Now, it didn't quite reach significance, and when they repeated the multi-center trial, they didn't see that fact. But that's an example where the 6-day randomized trial might have missed harm down the road. Multiplicity is the idea that if you ask or look for enough endpoints, one is bound to be positive. And the ratio is 1 out of 20 are going to be positive. But that's really a false positive. Perfect example is the Nephroprotect study by Doig. He had over 20 endpoints, and he had 4 different patient populations. That's over 80 endpoints. At the end of the trial, he had 1 positive finding, and it was creatinine clearance on day 3. Well, that really is multiplicity. That probably is a false positive. It was a negative study, but he didn't pitch it that way. And finally, greater flexibility is not a good thing from a validity standpoint. Research findings are less likely to be true with more flexibility. A perfect example there, pragmatic studies or real-world experiments, as I'll show you in a minute. Large randomized trials are not flawless, and that means that no study is so good that it supersedes all other trials. Obviously, the large randomized trials should get our attention and should help direct therapy more than others, but they're not infallible. Ioannidis says 10 to 15% of the largest randomized trials will be refuted. 25% of the smaller but still well-designed trials will be refuted by future studies. Some studies we have to worry about type 1 and type 2 errors. Type 1 error is that there's an early difference, but if you added enough more patients, that difference would disappear. A perfect example is the Arabi single-center trial in which he showed that underfeeding significantly reduced mortality. But when he came back and studied it again with 4 times more patients, that difference disappeared. A beta error is a thing that you don't see a difference early on, but if you kept entering enough patients, a difference would eventually emerge. Example here of a potential type 2 error is Eric Charles' trial of permissive underfeeding in trauma. He showed at the end of his trial that the trauma patients that got permissive underfeeding had the same outcome as full feeding. But his power analysis said he needed 116 patients. He only entered 80 patients. So you wonder if he had fulfilled the power analysis and entered more patients, if a difference would have appeared. even if you have a large randomized trial of 1,000 or 2,000 or 4,000 patients, ironically, it could still be underpowered. Here's a slide that shows the mortality in the control group for 30 years of ARDSNet trial studies. This is that NIH study group that has done so much for our critical care in the United States. When they started 30 years ago, the mortality in the ICU was close to 70%. Now the mortality is below 20%. And that mortality is the event rate. And as that gets lower and lower, it gets harder and harder to show the benefit of your treatment. Your treatment might be trophic feeding or volume-based feeding or enteral feeding. And you're going to do a trial to show that that therapy lowers this mortality even further. That's called the delta rate. Well, the lower this event rate gets, the lower the delta rate. It means you need bigger and bigger and bigger trials. Also, if you did your power analysis 5 years ago and it took you 5 years to complete the study, well, the mortality rate now is half what it was when you designed the trial. And if the power analysis said you needed 1,000 patients, now at the end, you really need 2,000 or 4,000 patients. So even these large randomized trials may be underpowered. We love meta-analysis because it allows us to tease out a treatment effect from multiple smaller RCTs. And it gives you an idea of the strength of the literature at a glance. You can see by these confidence intervals, these horizontal lines, that they're either all in agreement or all in disagreement, and it gives you a feel at a glance. The grade classification that's been adopted by nearly every scientific society standardizes the quality of evidence for the individual study, but it gives us no recommendations at all for selection criteria. In other words, you're on your own whether to include or exclude studies in a meta-analysis, and that's a huge problem. And in one disturbing reference by LaLaurier, they had 12 instances where they did a meta-analysis and then came back and did a large subsequent RCT. 1/3 of the time, the subsequent large RCT reversed the findings of the previous meta-analysis. So that shakes our confidence a little bit. And now, real-world experience. This is kind of the new kid on the block in my mind. The definition of real-world experience is this is data we get day by day under normal conditions outside the confines of a randomized controlled trial. It's supposed to complement the randomized controlled trial and build on the generalizability of those trials. An example would be a survey or a tumor registry or a trauma registry, electronic health records, social media, insurance claims. There's great value in this data because it allows us to focus on, quote, real world experience and the general care that's delivered, not just the efficacy of a single treatment that we'd see in a randomized controlled trial. And it's cheap. It's a cost-effective way to evaluate safety, patient response, or economic issues. It can allow us to extrapolate data from a very tightly controlled randomized trial to other populations. Say the original trial excluded diabetics and patients with congestive heart failure. Well, you'd use real-world evidence to extend the findings to include those new populations. The flaws are threefold. The data can be all over the map. It can be very good or it can be very poor. There can be incomplete databases, holes in the database, and obviously there's going to be greater likelihood for bias. In an interesting report from Poland, the national government there was deciding what drugs to cover in their national healthcare program. They looked at real-world evidence, 89% of which were cohort studies, and experimental evidence, 97% were randomized controlled trials. Look at the high quality. The experimental evidence, the randomized control, that only 66% were considered high quality. And look at the real-world evidence, 50% were high quality. And when they went back to say, what made us decide to cover the drug or not, 45% of the information came from real-world experience. And finally, in conclusion, remember the point of this is we learn the truth in science from all these forms of information. Remember that evidence-based medicine, only 1/3 of it is based on the quality of evidence in the literature. 1/3 is patient values and expectations, but 1/3 is our individual experience and expertise that we accumulate over time. There's a reason that the attending is ultimately responsible for patient care and not the first-year intern, which means that management treatment decisions should be based on the totality of information that comes to us and we should consider all of them in the ways we manage our patients. And I'm going to finish there and go on to our next speaker. I'm thrilled to introduce Philip Press, and Phil's going to talk to us about nutrition in the surgical trauma ICU, why and how.
Thank you very much, Dr. McClave. Thank you for the introduction, and thank you for those brilliant words. Certainly very insightful. Brings me some pause about some of the data that I'm going to share with you shortly here, but I do think there's still a lot of value in it. As an aside, it's certainly very humbling, and I'm very honored to be a part of this panel, and certainly hope and trust everyone is staying safe in this very difficult time. My portion of this talk is going to be focused on volume-based feeding within the surgical trauma ICU. Given the variety of folks who are talking today and the variety of environments that we all work in, I do think it's relevant to share just a few words about what kind of patients I treat and the environment that I work in. Prisma Health Richland is an ACS verified level 1 trauma center located in Columbia, South Carolina. It's the largest trauma center in the state, and it's smack dab in the middle of South Carolina. So it's getting patients referred from all directions to us at all hours of the day and night. We're also the major teaching university for the University of South Carolina. So we have a wonderful complement of residents, fellows, and students all contributing to the work that we do. Our patients come to us through an ICU. We have a brand new, beautiful, shiny 18-bed surgical trauma ICU. You can see we have a relatively young patient population with about 600 patients admitted directly there every year. This serves the basis of our patient population for the research that we do. Our patients are significantly injured. They are polytrauma patients in the most literal sense. They have injuries of every variety, heads and spines, lungs, everything is that you can think of is injured on them, very often all at the same time. Open abdomens, organ injuries, bony fractures. And you can see also that we have a very significant percentage of penetrating trauma injury patients, 15, 16% per year. To put it in perspective, that's about twice the national average. So Columbia is unfortunately a very violent town with a lot of patients coming our way. Trauma patients undergo a unique and certainly an incredible amount of stress. And that stress ultimately results in a significantly increased catabolic state, significant fluid requirements for our patients, which yields significant inflammation, leading eventually to capillary leak. A lot of what we do in the trauma world is spend our time fighting what's known as the lethal triad of death, or as Dr. Moore has dubbed it, the bloody vicious cycle. And here's roughly how it works. Until proven otherwise, all trauma patients are in hemorrhagic shock. They're all bleeding from some degree of an injury. That active hemorrhage does a couple things. The blood loss results in hypothermia, and the resultant acidosis, the metabolic acidosis that results from this, combines with the hypothermia to potentiate coagulopathy. The coagulopathy, of course, then recycles back and causes more active hemorrhage. This goes on and makes our patients incredibly ill. The way that we try to help our patients is to, of course, fight this as best we can. It's important to realize that with regards to infection, that trauma patients don't come in infected, that they arrive injured but otherwise healthy. And over the course of several days or weeks, we actually allow them to become infected. Central lines, Foley catheters, hardware that's left in place, dirty, open, contaminated wounds, these things become infected over time. And it's that degree of infection, that course of their hospitalization that causes them to be infected. So with this as our background, we set out a few years ago to see how we were nutritionally supporting our patients and how we could make any improvements in that. Our dietitian keeps a meticulous database so we could evaluate where we started and track our efforts along the way. So this is where we started. This was in 2011. And as you can see, it's really not very impressive. We didn't start our enteral nutrition until about day 4. We would reach our 80% of our nutritional goal day 9 at best, if ever, on average. Less than half the time we ever met our caloric needs or our protein needs. We didn't have any formal enteral nutrition protocol in place. We were using whole protein formulation with protein boluses. In short, we were doing it by sort of, a dealer's choice each and every day. Things changed. And so in seeing where we started, we really needed to set out a path of how to get to a better place. We needed to not be having delayed start times and variations in formulations. We were starting at such small areas and holding for procedures. We needed ways to get to a better and more stable place. And of course, the irony of this is that by 2009 already, we knew better. These guidelines had been out for a couple of years, and they supported early enteral nutrition. They had an emphasis on volume or on calories. And so we knew where we needed to go, but we didn't really know how to safely get there. So for the simple-minded surgeons among our crowd, to break this down like me, we needed to know really three things: when to feed, what to feed, and how much, and how to safely and effectively go about that. So when to feed? Well, we delayed long enough that by 2016, there were already other guidelines out from Aspen, which supported the use of enteral nutrition over parenteral nutrition in all critically ill patients. And the early enteral nutrition was recommended to start within 24 to 48 hours. And of course, there was more emphasis on protein by this time than simple calories. There was good data behind this. McClave et al. Published a large meta-analysis of 21 randomized controlled trials, 13 of which specifically reported on infection. And you can see that both within infectious morbidity and overall mortality, there was a reduction with the early enteral nutrition. There were some reasons to suppose this to be the case. Overall, there was maintenance of gut integrity and, of course, modulation of stress and the reduction of the SIRS response. All of this, of course, independent of disease severity. I would highlight that modulating the stress or the reduction of the SIRS response is something that someone who spends his life trying to fight the lethal triad of death sounds very, very important. So this sounds like a very good thing. Moving on to what to feed, again, going back to the guidelines, both with regards to severe traumatically injured patients, as well as specifically traumatic brain injured patients, the recommendations were to use arginine with supplementation. So some degree of fish oil and omega-3s to enhance that arginine delivery. Again, there's evidence to support this. Drover et al. Had a large randomized controlled trial evaluating pre, peri, and postoperative use of arginine supplemented immunonutrition on outcomes. And you can see that overall primary outcomes, there was an overall reduction in infectious complications. And with regards to secondary outcomes, there was a reduction of hospital length of stay. When looking at some various sub-analyses, we see that actually specifically it's arginine that's supplemented with omega-3 nucleotides, which shows the big difference. And so it's really the interplay. It's the interplay of arginine, the omega-3 fatty acids, and the RNA nucleotides that help support the immune and vascular response to our significantly injured patients. Again, with regards to the lethal triad, this seems to make a lot of sense. So now the question is really how to go about delivering all this. How do we evaluate our patients for what their needs are, and how do we effectively and safely deliver what they actually need? Of course, we know that trauma patients are very high risk. They have high protein requirements and high caloric needs as well. Each and every day, we calculate the Penn State equation on all of our patients, and we have a very energetic and very supportive respiratory therapy department that allows us to calculate indirect calorimetry on our appropriate patients up to twice a week as standard and more if necessary. So we're able to get a lot of information on patients in terms of what actually our goals are going to be. And of course, despite the fact that patients are very high risk in the surgical trauma ICU, we also know that there's a lot of interesting and unique challenges to a surgical trauma ICU patient. These patients are going through multiple surgeries over the course of their hospitalization, which requires them to be NPO at midnight, many, many nights, sometimes many nights in a row. My favorite is the ortho add-on diet. These are the poor patients who have an injury that get added on by our brilliant orthopedic colleagues. It's supposed to be an 11 o'clock operation. A few more accidents happen. They're NPO. It gets pushed to 2 o'clock, 4 o'clock. The night team comes in. They can't handle it, so it gets pushed off the next day. And we find out at about 7 o'clock at night. So the patient gets a few hours of nutrition, possibly at a low rate, before being NPO at midnight, and the whole cycle starts all over again. Open abdomens, while not a strict contraindication to open feeding, we have to realize why their abdomens are open in the first place. Normally, they've undergone horrible catastrophe. Oftentimes, their GI tract is in discontinuity, or they're so hemodynamically unstable as to preclude their abdomens being closed. So these patients are often not able to be fed enterally. Of course, many of our patients have abdominal pathologies, gunshot wounds, blunt trauma to various parts of their abdomen requiring ileus, things that do not necessarily make them excellent candidates for aggressive enteral nutrition. And of course, many of them even just have gastric intolerance. Neurosurgical patients, traumatic brain injured patients often have intolerance to the GI tract, making feeding in this population even more difficult. So again, going to the guidelines, we needed to see what was easy to change and what we could institute without a whole lot of difficulty. Assessing the patient, we've already discussed. Initiating the enteral nutrition within 48 hours seems like a good idea. Taking steps to reduce risk of aspiration is a huge emphasis, of course, across the whole hospital. But what we really need are protocols within the ICU to make this happen. And what we need to more specifically address is our gastric residual volumes as part of routine care to monitor ICU patients on our enteral nutrition. In terms of looking at protocols, this is the one that we settled on, the Enhanced Protein Energy Provision via the Enteral Route Feeding Protocol, otherwise known as PEPUP, started by Dr. Hyland several years ago. This was the first major study that his group came up with. It was a smaller study, but it was really their first one. And they looked at a group of patients where they started semi-elemental peptide-based formulations. They started at 25 mLs a day, added prokinetics and protein powder as necessary. And on day 2, they were able to get their rate up to their 24-hour target volume. Of note, they allowed a gastric residual threshold of about 300 mL. So more than some places were accustomed to. They did a larger multi-center trial a few years later, and they compared their PEPUP group to a control group. And what they found really mirror images of each other. They found that they were better able to deliver both calories as well as protein. This graph is adapted from that study. This is the one that's really looking at overall calories, but again, the calories and the protein ones mirror each other. And you can see a few different things from the 4 different curves there. Patients who were kept NPO, predictably, did not reach their calories much at all. Patients who were given trophic feeds eventually got to their caloric goals, but it took them a long, long time to get there. Patients who were given feeds and were progressed towards an hourly goal rate did eventually reach their goal nutrition as well. But you can see these peaks and valleys over the subsequent days. Peaks and valleys to me are very disconcerting. We really try to maintain a level of homeostasis in our patients, and stability comes from stability of all areas of their treatment plan. And trying to get them steady states is really important. And you see the steady state when you see the patients in green who were who were subjected to the PEPUP protocols. They got to their goal rate very quickly, and they maintained it almost perfectly evenly throughout their ICU course. Importantly, this important work by Dr. Hyland only included 4 trauma patients. And we see this throughout a lot of the nutrition literature. Because of those unique challenges to STICU patients, a lot of these larger trials do not have a lot of trauma patients included in them. And so now we were getting closer to where we needed to go. Between 2011 and present, we were no longer delaying start times or varying tube feed formulations. We were starting within 24 and 48 hours of stability. We were using a specific high-protein, semi-elemental immunonutrition formula, a supplemental arginine and omega-3 fatty acids and nucleotides. We started at 25 mLs per hour after stability on day 1 and increased straight to goal on day 2. There was no ramping up. There was no increasing. It was very, very clear. Go to goal on day 2. And we had a very formalized what to guideline for our nurses with a very specific gastric residual program. So this is what we actually did. This is the packets that we gave to our nurses. It highlighted the PEPUP protocol. We had, so we began this in August of 2013, and we really allowed 6 months of education between educating each and every nurse between day, night, all of the PRN nurses, the nursing educators. The dietitian would participate in rounds to help explain it. And we surveyed folks along the way to make sure that we were all on the same page. The gastric residual program, or the gastric residual volume policy that we instituted was slightly more aggressive than what was initially proposed. The idea is that we really don't hold our tube feeds until there's either emesis or until a secondary sign of intolerance. secondary sign of intolerance being either abdominal distension or abdominal pain. In this situations only do we check our gastric residual volume, and we only hold it if it's more than 500 mLs. If it's less than that, we decrease it if there's still signs of intolerance. Otherwise, we simply give it back to the patient and trial it again. So we're pretty aggressive. These are laminated and put at the bedside chart for all of the nurses to have. And so we did all this stuff to all of our patients, and we wanted to make sure that we were doing a good job at it. So we looked at a couple different things. This was really a feasibility pilot that we did after the first initial initial start of the program. This was looking specifically at 50 TBI patients, really to see if we were making a difference and if it was safe. And if you remember back to the slides where this all began in 2011, this was a huge improvement. We were now getting goal to over half of our patients by day 3, and about 78% of our patients were meeting their protein and calories by day 5. So it seemed like we were going the right direction. We should continue the program and study it on a much larger scale, which is just what we did. So this was a larger retrospective review, which we recently published, and this was looking at a much larger number of patients, close to 500. And what we did was we took a large number and compared them to a historical cohort to make sure that we were, again, making progress and doing good for our patients. All of these patients were ordered a volume-based feeding protocol with immunonutrition containing arginine and omega-3 nucleotides and compared again to the historical cohort. And this is what we reported as our findings. You can see the pre-volume-based feeding category and the post-volume-based feeding category, and a lot of significant differences between them. The first was the injury severity score. All of our patients are pretty sick, but you can see that more recently, and in the post-VBF category, they're even more sick. Our blood glucose, we were able to have much and significantly lower episodes of hyperglycemia, and we were also able to have better glucose control overall. In terms of our energy and our protein needs, we were able to give statistically more protein as well as calories, or said again, we were able to have a much lower protein deficit in all of our patients. Oops. Sorry, wrong button. This is a way to look at the effects of our protein that we deliver to our patients. This is an effect plot. So all of these circles are an individual patient as time goes on in the ICU. So as time goes on up to day 30, you can see there's obviously less patients in the ICU. And what we see is that in the pre-volume-based feeding protocols, those patients really never catch up to their 80% goal. They never reach the degree of protein that is being delivered in our PEP-UP or our volume-based feeding group. Surgeons are a little slow and need a little extra prodding, and so we like big numbers that are very easy to understand. So odds ratios are things that always catch our attention. And what we see in that our post-PEP-UP group, the odds ratio of meeting our protein goal was nearly 12. Again, we saw nearly mirrored image for our caloric goals compared to our protein delivery. Here again is the effect plot of our volume-based feeding on calories. What we see here is that our pre-volume-based feeding category does eventually catch up to our post-PEP-UP group, but it's not till after 30 days. So certainly after their most critical time in the ICU has been spent. It was important that we tease out the effects of gastric residual volumes on all of this. It might stand to reason that with less interruptions and less scheduled checks on our gastric residual feeds, that we might see more calories and more protein delivered. It turns out that that's not actually the case. If you look at our pre-PEP-UP groups compared to our post-PEP-UP GRV checks and our post-PEP-UP no GRV checks, you can see that those two categories on the right are almost identical. In other words, it was not the GRV protocol that actually allowed us to deliver more protein and calories. It was the PEP-UP protocol or the volume-based feeding protocol that allowed that to happen. The GRV checks help simplify things, and it helps streamline how we went about our delivery of enteral nutrition. And it certainly made life for our nursing staff easier in that there was less scheduled things to do. But it was not the variable that delivered the protein or the calories. Of course, nothing is really good if it's not safe. So we need to make sure that what we were doing is actually safe. And what we found was that it was actually very safe. In terms of our macro aspiration events, we actually saw less episodes in our post-volume-based feeding group. And in terms of emesis, there was slightly more emesis, but it was not statistically significant. The glycemic control, I think, is incredibly important. It's one thing to say to devise a protocol or a program that's going to deliver more protein and calories, design that carefully, implement it, and then get excited that we in fact deliver more protein and calories. That is something that we should expect. The question is really, what good is it doing our patients? There's so many variables within the ICU that sometimes variables are very hard to tease out in terms of what's actually happening with our patient population. But I think most would agree that glycemic control is a very useful surrogate for overall how well patients are doing. Patients tend to get hyperglycemic when things are going bad. It's not a question of controlling their glycemic index or their glucose with a glucose drip or a very aggressive insulin protocol. That's really not what it's about. It's about getting to the root of what's going on and making sure that that's the problem. So what we saw is that in our overall glycemic control, we had less episodes of hyperglycemia and less episodes of hypoglycemia. So our patients were overall better. And just as a final point, there was one more interesting side effect, is that our patients in the post-VBF group, actually more of them and a higher percentage carried a diagnosis of diabetes. So while you might have thought that the glycemic control should have been harder, it was actually easier and better controlled in the group. And again, I think hyperglycemia is an interesting and useful surrogate for overall how patients are doing. We know that when this is done poorly, patients do not do well. And again, it can be a marker of bad things to come. In terms of our secondary outcomes, there was really no significant changes in mechanical event days, length of stay, or hospital length of stay. But again, these were patients that were more sick, and so we might have expected them to fare worse, and that was not the case. As a final added bonus, we saw that TPN use actually went down. In our post-volume-based feeding group, we actually saw less patients and spending less days on TPN. This, by the way, in an era when TPN use seems to have increased throughout America. So our conclusion was that VBS with no gastric residual volume checks in a surgical trauma ICU is safe. It's more effective at the delivery of nutrients, including immunonutrients. It's preferentially effective at delivering protein, and overall improves glycemic control and decreases the use of TPN. So our suggestions are to feed early, use a well-tolerated and evidence-based semi-elemental immunonutrition formula, and really form a change team that has both strong physician leadership, a strong dietitian who's very willing to actively engage in the process, and a strong nursing leadership with a dedicated nursing staff capable and willing to perform all this. Thank you very much.
Applying it to everything. Yeah. I don't know if you heard the first part there. Philip, that was a great example of a sophisticated team taking information from the guidelines and from the literature, changing their practice and delivering optimal care to patients. It's an amazing experience that you shared with us. We'll move on now and listen to Zudin Puducherry talk about protein needs across the continuum of care.
Hello, everyone. I'm hoping that I'm unmuted, so that's good. I'm going to talk about protein needs across the continuum of care. As Steve pointed out earlier on, that perhaps I might have a slightly different view from many of the other speakers, and I think it's important to point out that I do this. It's all about improving the field of science to improve the care of our patients. Okay. Just not sure. Sorry, I'm just struggling to advance my slides at the moment. Oh, click it up, so that should work. Yep, okay, great. So my disclosures, I work with these various companies, either giving talks, but more specifically developing new compounds for the prevention of muscle wasting in critically ill patients. So when we talk about protein in the continuum of care, I think it's important to discuss what we mean by the continuum of care. So I think first I'm going to start to define acute and chronic critical illness. If you look at trials which have defined most of our acute critical illness periods, we've looked at most trials look in the first weeks, of 0 to 7 days, to define acute critical illness. And separately, in some of our epidemiological work, we've seen over and over again that there's a transition to this thing called persistent or chronic critical illness sometime between 7 and 10 days. And it's startling that every single academic group who looks for this looks to find between 7 to 10 days. So there's a spectrum of time around this, which affects 16% of our patients But these 16% of our patients consume between 25 and 50% of our healthcare resources. So we have this transition between acute and chronic critical illness. The problem with these definitions that we have now is that it's very difficult for them to make a difference at the bedside because they don't really take into account inter-individual variation and allowing us to make those judgments at the bedside. So I much prefer the biological response to insult approach, whereby we look at acute illness being a period of multi-organ failure and a systemic inflammatory response syndrome, and then a development of chronic critical illness as one develops markers of persistent inflammation, immunosuppression, and muscle wasting. And this was first described by Judith Nelson recently, well, not first described, it was described a little while ago, but this particular conceptual framework comes out of the Gainesville group, and they described this in 2010. And I'm going to come back to this. So we'll start with acute critical illness when we have multi-organ failure and the systemic inflammatory response syndrome. And I'm just going to put it out there that protein delivery in acute critical illness has yet to convincingly show functional benefit. I'm going to start by saying, I'm going to go back to Steve McClave's talk and say, looking at the quality of evidence is really, really important. Looking at where you derive these statements from is very, very important. So I'm going to quote Steve, who said, I mean, obviously, it's a huge group of people writing this, but in the Aspen guidelines, it suggests the high-dose protein should be provided. Requirements are 1.2 to 2 grams actual body weight. Quality of evidence, very low. That says to me, that's not very convincing. On this side of the pond, we've got, during critical illness, 1.3 grams per kilo protein equivalents per day can be delivered progressively. Greater recommendation, 0. No evidence to support this, but a strong consensus. So, as a clinician treating patients, I think you have to say that we're going on best opinion, but without evidence-based practice. So, what we have currently we have Darren Halen's group, which is a huge, almost consortium approach to randomized controlled trials, looking to build the EFFORT trial. Well, they're doing a multi-center registry-based trial looking at high-dose protein versus low-dose. This year, the ANZIX group just finished their target protein feasibility trial, where they plan to go for high-dose protein versus conventional treatment in the same fashion as their target calories trial. So we'll see whether these things can be tested in prospective randomized controlled trials at large numbers. In the meantime, it's important to consider the science behind these recommendations. So just to remind you that in a critically ill person, muscle protein synthesis is decreased on the first day of critical illness to levels associated with our fasted controls, despite the provision of feeding. And there's variable recovery over the first 7 days. And protein synthesis is incredibly important because we need to increase protein synthesis to increase muscle mass and improve functional outcomes, which is the basis of what we're trying to do right now with nutrition and our patients. What we often don't talk about is the energy component of protein production. And 40 to 60% of all energy, or ATP, in our cells is used for protein synthesis. So it makes no sense to a physiologist or biologist to separate proteins and calories. To give more of one without the other seems nonsensical. And I think the same would be true for our patients. Patients don't recognize guidelines, they just do what they need to do. So if you look at the energy requirement for protein synthesis being this high, we ought to look at how much energy we generate. Well, in earlier talks, we've talked about some of our data where we looked at ATP content. And the ATP content of muscle in the acute phase is low. What we have here on the first day of critical illness, patients dropping ATP content significantly. Obviously, there's heterogeneity in this, and patients with chronic disease drop their ATP content far faster than those without chronic disease. And this is true of the exercise literature. If you took myself and someone with COPD, we would both have the same resting ATP content, but if we did exercise or had any form of metabolic stress, someone with COPD would drop their ATP content faster. Regardless, over the first week, during acute critical illness, patients drop their ATP content despite the provision of nutrition. And in other talks at Aspen, we've talked about why this is because of the inability to metabolize carbohydrates from hypoxic inflammation and impaired beta oxidation. I don't want to go back over that, but we have to think about what the implication of impaired protein synthesis will be in the acute phase of critical illness when you then give people protein. So I'm going to share with you some unpublished data, which we're going through at the moment. I'd be grateful if you wouldn't tweet this. And then we teamed up with Darren Halen's team group and to look at the Redox trial, which many of you will be familiar with. So this is a randomized controlled trial of 1,223 adult critically ill patients who were randomized to supplemental glutamine, antioxidant both, versus usual care and 28 mortality outcome. And the original trial showed a increase in mortality with glutamine with an odds ratio of 1.28 and an increased hospital mortality and 6-month mortality. And one of our PhD students, Ryan, who was meant to be at Aspen, but clearly is not, is performing or has performed a post hoc secondary analysis to describe the 90-day risk of death associated with different urea to creatinine ratios trajectories among patients with multi-organ failure. Why this? Well, if we look at the urea to creatinine signature, we think that this probably embodies a sort of a biochemical signature of muscle wasting and cachexia in the critically ill patient. Bearing in mind the first descriptions of urea to creatinine ratios that came a long time ago, pre-PubMed, pre-Google, possibly pre-Steve McClave. I don't know if that's possible, but this is true. Okay, so talking through this, we have critically ill patients. Sorry, Steve, I couldn't resist that.
You're in trouble.
So critically ill patient has I know this is a busy slide. This is the only major biological thing I'm showing you, okay? So you have multi-organ dysfunction, inflammation, abscess, and mobilization, plus exogenous nutrition gives us lots of protein broken down, taking up energy and releasing ammonia. More glutamine results in more ammonia production, and all this feeds into the urea cycle and generates urea. Urea being probably a surrogate of all this ammonia being produced, increasing your urea. At the same time, we're increasingly understanding that creatinine is not a good marker of renal function. And in fact, some work from John Prowl at Royal London, the Karolinska Institute, and from Gainesville, Florida, are all showing that creatinine is really a marker of muscle mass, and it decreases rapidly over time in a critically ill patient. So what we think we see is this urea to creatinine ratio, where the urea goes up when you're sick and creatinine goes down, is a marker of abnormal metabolism. That's the hypothesis, okay? So we took the data from the Redox trial, because the Redox trial was fabulously carried out, has so much rich data for us to learn from. And we used cluster analyses to see, are there different clusters of urea to creatinine ratios? And three groups turned out. We then looked at survival within these clusters, and this is what we saw. If you had a low urea creatinine ratio, you have this trajectory of survival, and as your urea to creatinine ratio increases, you have an increased mortality. And there are reasonable numbers of patients on day 10 with urea to creatinine ratios. So we're looking at about studies of 500-600 patients. So in this analysis, increase in urea creatinine ratio, our purported biochemical signature of protein dysmetabolism, I guess, is associated with mortality. So we went back, because what we're saying is that this urea is being generated by both endogenous protein and exogenous protein. And we modeled and said, well, what happens if we have all these different levels of exogenous protein when you're critically sick and in multi-organ failure? And this is what we saw. If you had normal metabolism, then you do actually have some separation with increased protein. But if you're one of these people who has a high urea creatinine trajectory, i.e. you've developed abnormal metabolism, then the provision of extra protein increases your mortality. Now, you may think, gosh, that's new, but actually it's not new, because you can look at the ePanic trial, you can look at our observational work in the past to suggest that in some patients, high protein concentrations are dangerous. And I think this would be really interesting to see how this comes out in the effort trial. So Darren's going to put the urea creatinine ratio into one of our, as a sub-study into this. But it comes down to this concept of personalized medicine. Do you really think that every patient has the same requirement? Do you really think that every patient undergoes critical illness and has the same changes in metabolism? I don't. I think some people respond differently to critical illness. And for those of us going through the COVID-19 pandemic, we're seeing that in front of our eyes right now. We can't tell why some patients do badly and some patients do well. And so our working hypothesis is that we can pick out these people. And I've noticed that I'm saying it's a working hypothesis. I'm not saying go out there, I've solved this. I'm saying in a prospective randomized controlled trial, we're going to test this to see whether in those patients with raised urea to creatinine ratios, exogenous protein increases the risk of persistent critical illness, as we did in Ryan's paper, original paper in intensive care medicine. Is it increase the risk of low return to home rates? And this paper in Crit Care Med, published just a couple of months ago, found the same thing. And does it increase the risk of mortality, which is what our recent reanalysis of the Redox trial shows. So this is why we stand on acute critical illness, in that there was clearly a group of patients who don't do well with increased protein in acute critical illness, and we need to understand who these patients are before we have blanket recommendations to give a lot of protein to everybody. If we move on to chronic critical illness, well, what do we mean by this? We have acute critically ill patients. Some survive, some die, and some do neither. And they're stuck on the intensive care unit with huge amounts of muscle wasting and the need for ventilation in many cases. So we've updated this to say that these people who are on the intensive care unit requiring single organ support, including renal replacement therapy. And we know that these cachexia syndromes can last for a long time. Well, we described the first week, Lena Gammon-Grippenberg from the Karolinska Institution described what happens in long-stay ICU patients. And it can take up to 30 days for protein synthesis to normalize. And at this stage, protein breakdown increases, giving us our persistent cachexia state. Now, in this setting, we have a lot of problems. Patients have been immobilized for quite a while in chronic critical illness. And immobilization is a problem in that it's an anti-anabolic stimulus. It will prevent muscle growth. And we know that despite all these discussions that we have about early mobilization, we just don't do it well. These are recent, this is a slide from Linda Dennehy, who gave me, showing that actually across the world, even in centers that don't that have mobilization champions, we're very bad at mobilizing non-intubated patients, and very bad, even worse, at mobilizing intubated patients. And I'll put it to you that some of the work that actually we may think we're very good, but when you look at this subjectively, this is not true. So ask yourself, has there been objective evidence in your intensive care unit that you're very good at mobilization? We'd like to think that you can perform exercise on these patients, and exercise plus nutrition builds muscle. Unfortunately, the critically ill patient who's recovering in chronic critical illness has a very, very low tolerance of exercise. So this is some work done from the Netherlands that shows that the median duration of exercise in a chronic critically ill patient was 6.1 minutes at 5 watts with a Borg score of 13. So that means it took them 6 minutes to get into the chair, and they found that very, very, very breathless, very, very distressing, and made them very breathless. That is not sufficient exercise. So a chronically critically ill patient can't do exercise, which is what you need to do in conjunction with feed the patient. So nutrition in this setting needs to take into account the exercise. What's next? Oops. I'm trying to click on it. So I said that already, sorry. Inflammation is the second thing. So the chronic critically ill patient is inflamed. That is one of the hallmarks of it. So this is some very old work, again from the Karolinska Institute, showing that if you inflame people, they drop their muscle protein synthesis. And the critically ill patient has intramuscular inflammation. This is some work we looked at muscle biopsies, and we found a large number of intramuscular cytokines by day 7 in these critically ill patients. And this has been shown repeatedly by other groups. While you're inflamed, therefore, when you're chronically critically ill, it's pointless giving people more protein or doing exercise. One, because they can't do the exercise, and two, because they can't use the protein. So protein nutrition in this setting needs to be done in the context of inflammation too. And all this results in substrate switching. As you become more and more inactive, you're less and less able to use glucose efficiently. And this is what we see in the critically ill patient. We have insulin resistance in people who are immobilized, and Stefan Weber-Carstens demonstrated the biology behind insulin resistance in the critically ill patient, that of poor GLUT4 translocation. We're less able to use fats in the critically ill when you're immobilized, and we showed a couple of years ago that beta oxidation is impaired, and we discussed this earlier on in the metabolamics session. As a result of this decrease in beta oxidation, an immobilized patient builds up intramuscular lipid, and it is as a critically ill person. And so you're unable to generate ATP for use for protein synthetic, for protein, muscle protein synthesis. So in summary, in the chronic critically ill person, so I'm showing the ESPEN guidelines in the ASPEN talk conference, but that's what I've been asked to do. We have to think about physiology, okay? We have to think about the acute phase, and we have to think about when patients have an increase in anabolism and are able to start thinking about rehabilitation. And this is not going to be a day-related thing. It's going to be related to biology and individual patient factors. And we know this is happening because if you look at some work from Nottingham where they biopsied a whole bunch of patients, they can see changes in mRNA. So this is the genes that go on to develop the proteins for anabolic signaling. But at the beginning, these genes are not being translated into proteins, i.e. they're sitting there waiting for the moment to start building muscle. So there's an initiation of cellular program of anabolic restoration ready for the right time, when inflammation has gone away, when people are no longer immobilized, to start anabolic restoration. And that is the time to give protein. And if you don't, we just give protein in a fashion like this, what you see is this. This is Ryan's first publication last year, showing in a trauma population that the urea to creatinine ratio, what we think is our marker of abnormal protein metabolism, predicts persistent critical illness far better than any of the other epidemiological techniques used. And this is probably related to a combination of nutritional protein and catabolism, which is what I've just shown you. I'm going to finish off to point out two other things against blanket rules. Remember that nutrition and exercise as a combination is needed to stimulate muscle protein synthesis. So your protein recommendations need to take into account exercise and the performance of exercise. Secondly, we've known this for a long, long time, that the protein requirements need to be age-related to great muscle. In our lives outside intensive care, we're well used to the reverses, that young people eat huge amounts of protein, but you only need 0.25 grams per kilo to stimulate muscle protein synthesis, whilst older people eat less protein when they need far more protein to stimulate muscle protein synthesis. And none of our guidelines, the ESPEN, ASPEN, Australian guidelines, Canadian guidelines, take into account age of our patients and the personalized need for this. So where we are right now, I'd summarize this by saying there's no good evidence for blanket protein delivery during the acute phase. At this stage, it's more important to do things in a systematic fashion than it is to go off tangentially. And my unit follows the ESPEN guidelines. I still think protein delivery in the chronic phase needs to be considered alongside energy delivery and exercise, and you're seeing this coming through in the physiology of the ESPEN guidelines. And right now, we're developing new bedside markers for nutritional response. Thank you very much.
Let's finish up with Manpreet Mundi, If we'll go to the next slide, Preet's going to talk about management of home enteral nutrition and what happens in the patient that can't tolerate tube feeds. Preet?
All right, thank you. Hope you can hear me okay. But I'll take over and kind of talk about the post-discharge part of the conversation. And I think this is important to have because exactly what you described, Dr. McClave, that more and more patients are now having better survival through their critical illness. And so more and more patients are being discharged, and many of them need ongoing enteral nutrition. So these are my disclosures that are pertinent to this talk. And what I hope to do is share some data really about the home enteral nutrition population in general, which is rapidly growing. Talk about the difficulties that we continue to have both in the ICU as well as hospitalized patients and then post-discharge in terms of intolerance. And then some of the data that's emerging, especially from our own sort of review of our patients, that says maybe we aren't managing these patients as best as we should. So with that, I'll start with a case. I always like to ground myself in the patients that we treat. And this is a 50-year-old lady that we saw, had a history of obesity, complicated by diabetes as well as reflux. And she had a history of a Nissen fundoplication in 1999. But unfortunately, her symptoms of reflux returned in 2013. And at that point, the decision was made to convert her to a Roux-en-Y gastric bypass. So after she underwent this surgery, unfortunately, she started experiencing a great deal of postprandial abdominal pain. So initially, dietary changes were made, but there was no response. So they started to do further workup. And one of that workup was the upper GI series, which showed that there was a deformity in the gastric pouch. And so EGD was also done, and again, confirmed that perhaps the gastric pouch was too large, greater than 20 centimeters. So with this, decision was made to revise her surgery again. Unfortunately, that didn't solve the problem. She continued to have pain, nausea, and now even vomiting. CT scan was done to see if we missed anything else, and there was a finding of peripancreatic fluid collection that was drained, but unfortunately no resolution of her symptoms. So then another EGD was done. They thought there was a possible stricture in the EJ anastomosis, and that underwent dilation. But again, symptoms just continued to persist. Her weight during this time also began to decrease. And so we were starting to worry about malnutrition in this patient as well. Now, we don't have any questions and answer, but I just want you to think through. At this point, you're seeing this patient in your clinic, what should our next step be? And as we kind of work through this and look at all the choices, one choice is, do we still try to make oral intake work? Do we have her visit with a dietitian and see if that can work? Another option is, do we switch her to enteral nutrition? And again, how would we do that? Do we do that through a nasal jejunal tube? Do we put in a gastrostomy into that remnant stomach? Or do we think about parenteral nutrition? Do we think enteral is just not going to work? But again, looking back at the data, when we start to look at this decision we have to make, we can see that there's significant data that shows benefit from enteral feeds. And I think Dr. McClave says this best: if the gut works, we should use it. And so, I won't go through the details of this, but there's a lot of benefit in terms of preservation of architecture, in terms of immune benefit, and also our friends, the microbiome as well. There's also been studies that have looked at this, comparing early enteral nutrition versus other sources of nutrition, maybe even late enteral nutrition, and again, showing benefit in terms of early enteral nutrition. Critically ill, we've just had 2 great talks on this topic. Lots of data supporting early enteral nutrition in these patients. Also, I think, as we're seeing more and more data, parenteral nutrition is getting better and better and coming closer to enteral nutrition, but I don't think it will ever take over in terms of the cost comparisons. So I, along with Zudin, am also showing ESPN guidelines in an Aspen talk, but unfortunately, we are still progressing towards the Aspen guidelines on home enteral nutrition. So I'll be using the Aspen ones quite a bit for now. But again, taking a look at all of that literature, they also tend to agree that if a patient is not able to meet their nutritional needs through oral intake, we should move ahead with enteral nutrition support, especially if the gut is still functioning. Here are the reasons why we may want to avoid enteral nutrition, including contraindications to enteral nutrition. So that's there for your reference. But regardless, due to a number of factors over the last few decades, right, the better treatment of critically ill patients, lower mortality there, more discharge, combined with the fact that all of this data is emerging on the benefits of enteral nutrition, this has led to a tremendous increase in the home enteral nutrition prevalence. This is data from our study, and we compared it to work by Dr. Lynn Howard in the mid-90s, and you can see the prevalence of home enteral nutrition has almost increased threefold. So with that, data, when we're looking back at our patients and what's our next step, we also agreed that we felt her gut was still working. We wanted to see if it was something in the esophageal jejunal anastomosis, and could we bypass that and provide her feeds. So we went ahead with a G-tube into the remnant stomach and started providing feeds that way. So the next question ahead of us was, well, what formula do we start with? Again, we're starting to have a lot of choices, and kudos to the companies that continue to innovate in this field. But we've got big categories such as standard polymeric formula, those semi-elemental peptide-based diets, elemental formulas, and I think even a fourth category that we can add now, which is blenderized tube feeding. They're going to vary in terms of their macronutrient composition, including the peptide-based diets, which is going to utilize more hydrolyzed protein. So we're giving more di and tripeptides. And then the lipids also can change in macronutrients, comparing long-chain triglycerides that we may see in the standard polymeric formula to those using mostly or at least half as medium-chain triglycerides. And later on, I'll go into some of the theoretical benefits of those. But for our patient, we had the same decision. We were looking at all of our options. Do we go with standard polymeric formula? Do we add fiber? Do we not add fiber? Do we try and aim for a high protein formula, again, with or without fiber? Do we start right off the bat with peptide-based diet? Or, we think tube feeding is not going to work, and do we go with parenteral nutrition? So when looking at this, again, looking at the guidelines, the home enteral nutrition world needs a great deal of work. In terms of guidelines, so sometimes we have to extrapolate from other guidelines and recommendations. And in this case, most would tend to agree that standard polymeric formula is the way to start. So that's what we did. This was how we did it, and we chose the high protein formulation. But unfortunately, within a few days, as the formula increased in the volume that we were providing, she called us right back and said, unfortunately, she's having bloating with her feedings, increased abdominal pain, felt that it was like an ice pick moving around, and also was constipated. So now what do we do? Do we think that this is related to the constipation? Would adding fiber help? Do we think this is a component of malabsorption? And in that case, do we go with pancreatic enzymes, or do we go with the peptide-based diet? Do we think it's a fact that we're providing sort of gravity feeds and it should be continuous? Or, do we think about parenteral nutrition? So with this in mind, I started reviewing the literature and looking at intolerance. Again, a lot of work needs to be done, I think, for these patients to better define this. But if we look at the literature, especially the critically ill literature, ill patient literature, almost 30% in this one study that was a retrospective review showed that there was some component of intolerance. Again, they were also including large residual volumes, which we are starting to move away from, but many patients also had distension, vomiting, diarrhea, and discomfort. And this led to decreased calories being provided. Another study also looked at this, both for the ICU patients and then the non-ICU, non-critically ill patients. And they found that even in the non-critically ill patients, they still had high rates of intolerance. Again, what was a major shift, and I think very interesting, was that in the ICU, it was those residual volumes that was largely causing feeds to be held, whereas when they moved to the hospitalized patients, you started to see that it was more nausea, vomiting, more abdominal pain, distension, and even more diarrhea that was leading to issues providing enteral nutrition. So in our case, kind of looking at this, I think we prepared ourselves that intolerance is quite high and we should try to work with her. We still felt that perhaps it was constipation based, and so added some fiber to her formula. But unfortunately, her symptoms continued. And I bring this up because when we looked at this case, it really struck us the term healthcare utilization. So as this patient was not tolerating her formula, she was greatly using healthcare resources. She was calling us almost 7 times over this time period. She actually went to the ER. She had a CT scan, which was unrevealing. But as you go through that mentally, you can see the cost is starting to add up. So we don't want to neglect this intolerance and say, well, it's quite common. We need to develop strategies for intervention quite rapidly. And again, what would those interventions be, right? And I've listed the options here. In her case, we sort of continued along the path of providing enteral nutrition, sticking with the standard formula. Our group was very conservative in switching to other formulas such as peptide-based due to our perception that those formulas cost more. So we're trying to be, mindful of the healthcare resources that we use. So again, we continued along this month after month, and you'll kind of see we tried to change to continuous feeds. We added formula. We consulted GI. They recommended some Miralax and other medications. We stopped her oral intake. But over this time, her weight continued to decrease. She was calling our group constantly. There were a number of other consults that she went through. So finally, in the fall, we then transitioned her to peptide-based diet. And again, by this time, we were very nervous receiving messages from her. So when we finally got a message, we all looked at it and said, oh boy, let's see what is happening now. But to our delight, she was very pleased with this change, and in fact wrote, the symptoms of pain, bloating, gassiness, and general feeding difficulties have all but resolved. I'm starting to feel stronger, having more energy, doing my ADLs now without much effort. She said, I really feel that all of the changes I've made have definitely shown great benefit, and I'm so happy. So kind of a delightful message to get, from a patient. This is what we want. But it also prompted us to start looking at the literature and saying, is sort of our algorithm of treating intolerance appropriate based on what's out there and based on the results we're getting for our patients? And when we did that, there's a number of studies, and I'll again go through these quickly for the sake of time, but there's a number of studies that have compared peptide-based diet to parenteral nutrition. In this case, it was in patients with abdominal surgery. And they showed that most of the patients on the peptide-based diet post-surgery were able to tolerate enteral nutrition well and avoided parenteral nutrition. They again listed the cost difference between peptide-based diet versus parenteral nutrition. Another trial looking at pancreatitis. So this is, someone we know and love, Dr. McClave's study, looking at 30 patients that were randomized to either peptide-based diet or parenteral nutrition. These are the calorie targets and the protein targets. And you can see overall, enteral nutrition was just as good as parenteral nutrition, if not a little bit better in terms of trends. But again, cost-wise, there was an astronomical difference. Same thing. Now there's another group of studies that have compared peptide-based diets to standard polymeric formulas. In this trial, we're looking at patients with pancreatitis, again, randomizing them through jejunal feeds. And what they found was that tolerance was pretty equivalent. However, in the peptide-based group, the length of hospital stay was shorter, almost 4 days shorter. Again, so this started to, change in our mind, this concept of healthcare utilization. We were comparing standard polymeric formula to peptide-based diet directly and looking at the cost of that, but ignoring the rest of the healthcare utilization, including the cost of 4 days of hospitalization. So you can imagine that. Another trial looking at the HIV cohort, 80 patients here. And again, they showed with the peptide-based diet, those patients were able to maintain their weight better, maintain their fat mass, and again, had less hospitalization. So this then led us to our own retrospective review. We looked back the last few years and saw that we had almost 95 patients that were placed on peptide-based diet. Out of those, 53 were started directly and 42 were switched from another formula. So when we looked at that closely, again, this is a retrospective review. So we looked at the clinicians and how they were making those decisions. We started to see that they were making those decisions largely based on the thought that these individuals would have malnutrition. And so more of those patients were started on peptide-based diet. So this is the indication for that peptide-based diet. Again, more malnutrition in those started from the very beginning versus those who were switched. Most of the time that was occurring due to intolerance of a previous formula. Here are the formulas that were used by our team. But this is really the slide that kind of hit home for us in terms of our algorithm of how to treat this. Those individuals that were transitioned to peptide-based diet, you can see the dramatic reduction in symptoms. Nausea, vomiting was cut almost in half after the transition. Diarrhea, cut almost in half, significant reduction in abdominal pain and cramping, significant reduction in abdominal distension, and the patients with no symptoms, no issues, increased from almost 21% on previous formula to close to half on peptide-based diet. So pretty dramatic. But we also looked at healthcare utilization within our own group. And what we saw was that the number of phone calls that were initiated by the patient with complaints of intolerance were dramatically decreased. The number of ER visits based on home enteral nutrition intolerance were decreased, and then the number of visits were decreased. So it's very hard to kind of put this in terms of costs, right? Because of the way the U.S. healthcare system is and how the costs are sort of proprietary almost, the way they're negotiated. But if we look at the literature and try to look for equivalent studies, we can find some. So there's one study that looked at the average cost of ER visit for someone with constipation. And in 2011, it was $2,300 on average. So you can imagine what it is today. Another study looked at the managing of diarrhea. and found that it ranged anywhere from $3,600 to over $5,000, especially if hospitalization was utilized. So I think as we look at this, we have to start putting all of that into the equation to see what is the best cost-effective manner to treat intolerance. Fortunately for us, we saw this abstract, I believe it was in ESPN last year. Again, looking at this in a similar way, they were able to look at medical claims data for adults receiving peptide-based diet. So had much higher numbers, over 2,200 patients, and they found very similar results to ours, so which was quite reassuring. But again, dramatic reduction in symptoms of intolerance, and also a dramatic, statistically significant increase in patients who reported no intolerance with peptide-based diet. Just a few slides left on some of the theoretical basis for this. And what I've tried to show here is that, when we consume a standard polymeric diet or blenderized tube feeding, most of the protein is in the form of a large polypeptide, and that needs to be broken down into di and tripeptides. And then it's absorbed essentially through a number of channels there, including one that I think is becoming more important, is that's the PEP-T1. And I bring that up because what we're starting to see is that with studies that are looking more at this particular receptor, this helps us absorb di and tripeptides. Normally, it's really expressed in the duodenum and ileum, but in this study, they looked at short bowel syndrome patients and found that when the bowel was shortened, you started to see increased expression in the colon as well. So could the theoretical benefit of providing directly di and tripeptide is that could we be absorbing those proteins better? And that's why we're getting those results. Same thing with lipids, right? Most of our lipids come in the form of this large lipid droplet, and that is worked on by bile salts to emulsify it, and then the lipase breaks that down, releasing free fatty acids, and then that's absorbed through chylomicrons. With medium chain triglycerides that are found in these sort of peptide-based diets, those tend to get absorbed directly. And also, when we talk about oxidation, more of those long chain fatty acids need the carnitine transport to get across the double membranes of the mitochondria to be oxidized, whereas medium chain triglycerides can go in directly. So, with that, I'll close for the sake of time, but just to mention, home enteral nutrition is definitely increasing in prevalence, and I think we definitely need to develop a protocol for treating intolerance that includes peptide-based diets.
Thanks, Manpreet. I couldn't help but notice your patient got much better after you got a gastroenterology consult, but we'll say it's due to the formula alone. We've just got 3 minutes, so I'm going to ask one. We burned up with questions from the audience, and I'm sorry we can't get to all of them, but I'm going to ask one question each to the speakers. Zudin, I'm going to start with you. That was a fascinating discussion of the urea-creatinine ratio. Why do you think the protein increases mortality? And secondly, what percent of patients do we see the increased ratio? And do you use that ratio or clinical measures of inflammation and mobilization to decide when to advance your protein?
Great. So that's 3 questions. First question is, why does the protein...
Why does it cause mortality? Yeah.
So we think, it's a hypothesis, and I'm hoping to answer this question, is that while urea is not toxic, right, the byproduct of that urea cycle and increased protein is ammonia. And ammonia is toxic for your mitochondria and your protein synthesis. And if you join us, Steve, you're going to join us because we're talking together in the next session about this, and I'm going to talk a bit about ammonia. That's one. Mm-hmm. The second question was about...
What percent and what you use as your measure to say, okay, fine, I can increase protein.
Fine. So what percentage is, we don't know, because we literally have been working on this non-stop since last year, but we think it really depends on how sick the patients are. So you can see in the redox trial where they recruited really, really sick patients, we see it in multi-organ failure. So that's when we start to see it. And in keeping with good practice, because these are observational studies and retrospective analyses of randomized controlled trials, I cannot recommend that you change your practice right now. We are going to test this in a prospective randomized controlled trial, and we will practice good evidence-based medicine.
All right. Philip, on your presentation, we're focusing now on the phases of critical illness, and that early phases, we're worried about under-resuscitation, ischemic bowel. Do we suppress autophagy, mitochondrial dysfunction, glucose outpouring from the liver? Is it dangerous to jump to goal on the next day? Should we be cognizant of these phases? And the second part of this question is, where's the tip of your tube? Is it in the stomach or the small bowel, and does that make a difference?
Both fantastic questions. Thank you. I suppose I should have been more clear to assume that active and appropriate resuscitation happens. In our ICU, we do not feed if a lactic acid level is over 2, or if they are on Levophed or Levophed equivalents of over 12. So generally speaking, that is improved by day 2. But yes, certainly in the throes of an active resuscitation, when folks are sick, when their mitochondria are screaming for oxygen, and when blood flow is being shunted away from the GI tract, that is not the time to inundate it with a whole bunch of enteral nutrition. So yes, we have to resuscitate and stabilize first. In terms of where the NG tube is placed, we are very aggressive at feeding the stomach. We do not feed post-pylorically, or I guess more appropriately or more specifically post-ligament of Treitz, unless we have documented evidence of intolerance. So we feed the stomach first and go from there.
Does any of this change whether the patient has evidence of refeeding syndrome, they're on pressors, they're on paralytic agents, or they're pediatric patients? These are all questions from the audience.
Sure. Paralytic patients, if they're on paralytics, no. Doesn't affect gut motility, so we're aggressive with that. Pediatrics, I can't speak to. We, in our trauma center, per adult ACS trauma guidelines, we feed and treat and take care of patients 15 and up. So our patient population is 15 and up because of the IRB. The study only included 18 and up.
And refeeding and pressors.
Refeeding and pressors. So pressors, I think I spoke to again. We try not to use a whole lot of them. Generally speaking, pressors can be a way of changing the red number on the screen for the sake of central oxygenation. So hopefully you don't need a whole lot of pressors in your trauma patients if you're resuscitating adequately with blood and stopping the major problem. In terms of refeeding syndrome, yes, we monitor our electrolytes aggressively. If our phosphorus drops, we are very aggressive at replacing it. If it drops below 1, we hold our enteral nutrition and replace until we're in a better range, and then start at a lower rate. So we are slightly more gentle if there's evidence of refeeding.
Okay, Manpreet, feeding intolerance is an absolute can of worms. I've looked at this area. Nika Blazer from Estonia has spent a decade of work in this area. The definition over almost 90% of the time is based on high residual volumes, which is problematic. Nika Blazer adds things like presence of GI bleed, increase of intra-abdominal hypertension or pressures. How would you define feeding intolerance in this situation, and what parameters should we look at? And why would the peptide-based formulas work in that setting?
Yeah, I think when I reviewed the literature, that was the biggest difficulty I had. So I tried to look at, data that didn't look at gastric residual volume. And a lot of that data is coming from the non-critically ill patients. So there, when we look at intolerance, they essentially defined it as any sort of symptoms that led to a holding of the enteral feeds or prevented the patient from reaching their goal enteral feeds. So again, not a lot of literature present in the home population, but those are the criteria we tend to use. So any sort of GI discomfort, bloating, gas, all of those things that prevent the patient from reaching their goal feeds. So that's how we would define it. And then the second part of the question, I'm sorry, could you repeat that?
what parameters would you follow to tell you that you have feeding intolerance? And I think you answered that. Okay. So let me ask the follow-up question. Several of the audience participants mentioned cost. You were comparing your cost to parental nutrition, but what about the cost of the small peptide formula versus the standard polymeric formula? Do you get into problems with coverage for that?
Absolutely. And I think this is where, healthcare insurance has to catch up, because we were directly comparing peptide-based formulas to the standard polymeric and saying that the cost of those peptide-based is too high. And because of that, we should do everything possible to see if the patient can tolerate it. We weren't accounting for the cost of the phone calls, the cost of the visits, the costs of the GI, the gastroenterologist, who clearly fix, all of the problems, but regardless are quite expensive. Then the cost of ER visits, the EGDs, all the workup that goes into trying to solve that intolerance. So a lot of work has to be done, but I think when we start to put this together and compare the overall cost of intolerance, especially of not reaching goal, comparing that to the cost of peptide-based diet, I think you're going to start to see more adoption of this approach.
All right, that's great. We appreciate all these speakers. This was a fun symposium. Thanks for all your contributions, and we do need to close because we got to get ready for the next symposium.